morning, everybody. I'm going to talk a little bit about dyslexia, but it's going to be from the ophthalmological standpoint. And thank you for coming. It's quite a lot of people for this early hour in the morning. So we're going to talk today about developmental dyslexia. We're going to talk about what is it, try to define it. We're going to talk a little bit about the pathogenesis or the mechanism of developing dyslexia. And we'll also speak about the visual system and dyslexia. How do they connect? We will not talk about visual training for dyslexia, and soon you will understand why. And of course, I have nothing to declare. So learning disabilities are quite a common disease, and it concerns the child, his family, and also the authorities. Just some numbers. In the US, nearly 20% of children have dyslexia. About 5 to 18, depends on the study you read, % of people have learning disability. And out of them, about 80% will have some kind of reading difficulties. So dyslexia, reading difficulties are the same, because dyslexia is a Latin word which is divided into two words. The dys means no, and lectionis means reading loud. And remember it, because even if we read silently, we do read loud in the brain. So this disorder is related to reading written or printed words, and patients who are dyslexic struggle with the process of translating these words on a page into a corresponding sounds. Reading disability can be mild or severe. It occurs throughout the world, in any part of the world. It seems to affect boys a little bit more than girls. And it involves children with all levels of intelligence. A child that cannot see is not always a stupid one. And it can persist for a lifetime. Reading. Reading is a complex process of extracting the meaning from written symbolic characters. We have to change the words, the letters into sounds. And what do we need for that? We need the ability to see, meaning an intact visual system. We have to identify what to see, and we have to process it in the brain in order to understand and correlate the things we have seen. The most common mechanism for, the most accepted mechanism for reading is the dual root model of reading, which was first suggested by Foster and Chambers back in 1973 and has been very much developed since then. First of all, as we saw, we need a visual input. We have to see what we are reading, even if we don't understand it. And for example, I'm going to give you a word in Hebrew. You all see it. I guess many of you cannot understand what it means, but nevertheless, you see it. And this is the very first and very necessary part of reading. From here comes the other steps, and the first step is decoding, meaning trying to find out what is this word. So the first step will be dividing the word into letters. And from here, there are two pathways that we can choose. The first one is a long, inefficient, mostly technical, and this is the pathway we use when we start reading. And then when we become expert readers, we use the global reading, in which we know the words. We don't have to divide them each time we see them. So let's explain what is the technical system. In this pathway, we transform the graphical signs into sound. And I'm going to show you what I mean. In this word, which is named monit, I don't see the monit. I see the m, o, n, e, t. Means nothing to somebody who don't understand Hebrew. Let me give you an example that you will understand better. The word neuro-ophthalmology. How many of your patients will come to your room and will ask you, what does this long word means? Neuro-ophthalmology. Then you explain to them what does it mean. The next time, they will come to their neuro-ophthalmology doctor. So this is the first steps that are used for reading. They are inefficient, but then we know the word, we study it, and we store it. So when you become an expert reader and you use the global reading, you don't use anymore the technical way. You go straight to the technical, you don't use the technical system, you go to the global system, and you read the word, seeing the word and using previous knowledge. And now you become an expert reader. So what does this word monit means in English? It means taxi. Oh. So if you come to Israel, you don't have to remember the word monit, you can ask for a taxi, everybody will understand. Okay, so what happened in dyslexic patients? They have good visual input. You can have difficulty with readings, with problems in the visual pathway, but this is not dyslexia. This is reading disability due to cataract, due to cross-eyed, due to amblyopia, but not due to dyslexia. In the developing reader, there might be some interference from here in any other part of the process. And it depends where the interference is to what kind of dyslexia the child will have. And there are many kinds of dyslexia. Due to shortage of time, we will not go into each part of them. So to summarize, in the middle of the talk, we know now that dyslexia is separate from reading difficulties caused by vision problems, and that the underlying mechanism of dyslexia are problems within the brain's language processing. Are there any reading centers in the brain? Yes, there are. However, there is no single location in the brain that serves as a reading center. The brain uses existing area that serve for oral language and object recognition and adapt them to facilitate reading. Typical readers predominantly use the areas in the left part of the brain, and there are at least 4 known centers of reading: the inferofrontal Broca's area, the parietal temporal region, the occipitotemporal area, and the posterior inferior temporal cortex. We know now by anatomical and functional MRI studies that there are differences in the way the brain of persons with dyslexia develops and functions. Children with dyslexia use different areas of the brain when reading as compared to typical readers, even before they started to read. Readers with dyslexia use the inferior frontal Broca's area just as normal readers do. However, they saw dysfunction of the left posterior area, and instead of that, they use the right occipital temporal area in the right side and bilateral inferofrontal gyri. And this was proved by especially functional MRI study in recent years. So we've talked about reading and the eyes, and we've said that in order to see, we have to have an intact visual system, but we do need the eyes for reading. More than that, we have to accommodate, we have to converge because we're reading in near, and we have to perform series of saccades and fixations. Young children have large accommodative amplitude. Their near point of convergence in most of the cases is very close to the nose. Their average refractive error is low, so they can read comfortably at about 15-20 centimeters from the nose for a prolonged time. We use saccades in order to read, and we use saccadic movement of short duration and high velocity. The saccades length depends on the ability to recognize the letter, the length of the word before the saccades, and reading comprehension. The mature reader use approximately about 85% of the saccades in what we call a forward saccades. For example, in English, it's going to be from left to right. In Hebrew, it's going to be from right to left. But we still have about 15% of regression saccades, which means the reading will be like this. Okay? And the regression saccades are necessary. They are used for verification and comprehension and to start the next line. So we need to reverse. Saccade increases in number with increased difficulty of the text. If it's easy to read, we will read like this. Tick, tack, 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 tack. Go next to the next line. Tack, 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 tack. But if you want to see again the word, try to understand it, try to divide it, it's a new word. It will be tuk, 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 tuk. Depends on the difficulty of the text. Visual perception is suppressed during the saccades, and the information is perceived during the foveal fixation, or what called in the papers as fixational pauses, which consist of about 90% of the reading time, which means the saccade is short, we stop, we see the word, we move to the other word. So saccade is the eye movement is very important for reading. However, early readers and dyslexic readers use relatively shorter forward saccades, an increased number of regressing saccades, and longer fixation time. What about ocular abnormality in dyslexia? I mentioned in the beginning of my talk that there are no correlation between ocular abnormalities and dyslexia, and indeed, Krivin and his associate published a study, the biggest study on dyslexia and ocular abnormality. They checked about 5,000 children, 600 of them were dyslexic, and they found no association between dyslexia and strabismus, motor fusion, sensory fusion at distance, refractive errors, amblyopia, convergence, and contrasensitivity. None of them was related to dyslexia. However, they did find two ophthalmic abnormalities. One of them was poor stereo acuity, and the other was poor sensory near fusion. The distance wasn't correlating. They concluded that these two abnormalities may be the result of the reading problems or unrelated, but not the reason for the dyslexia. So in summary, we have learned that in order to see good, we need good visual input and with good processing. And first of all is the ability to see, then the identification of the word, and then the processing out of it. What we know as ophthalmologists is to examine the visual system. The treatment of a child with dyslexia should always start or let's say with reading difficulties, which is the same, but before we give him the diagnosis of dyslexia, we have to be sure that he doesn't have any reading difficulties due to either refractive problem, we'll give him glasses. Cross-eyed, we will fix it either with glasses or with operations. Stereo acuity, we cannot correct, but if the child has cataract or any other ocular opacity, we should use it. Other than that, it's a multidisciplinary team that you should treat the child with dyslexia. And I thank you for your attention. And
thank you very much, Hana. We will save your questions for all of our speakers at the end. We will have some time at the end. So it's my pleasure to introduce my co-chair, Michael Brodsky, who came all the way from Rochester Mayo Clinic, and will talk on the essential infantile esotropia. Thank you, Mike.
Thank you, Clara. For the past 20 years, I've been studying the evolutionary basis of infantile esotropia and the unique eye movements that accompany it. I've been doing this while all of you were laying on the beach drinking margaritas, having fun. And And I've come to the conclusion that contrary to the popular notion that this condition is embedded within the visual cortex, infantile esotropia and its unique ocular motor aberrations are subcortical in origin. So I'd like to take a few minutes to re-examine infantile esotropia through the prism of evolution, and I'm going to present evidence that infantile esotropia arises from a state of extended subcortical neuroplasticity. Here's a baby with infantile esotropia, and what's so amazing about this condition is that both eyes are held in an adducted position, even though the child can fully abduct either eye. So this condition has to be pre-nuclear in origin. But when the child is paralyzed under general anesthesia, the eyes are completely straight. So this condition has to be caused by increased baseline innervation or tonus to the medial rectus and inferior oblique muscles, which also overact under awake conditions. So it's not like neuro-ophthalmology where you have paretic muscles that underact. Infantile strabismus is a pre-nuclear disorder in which individual extraocular muscles truly overact. Now, in neurology, it's considered axiomatic that body movements, if I move my arm, body movements are innervated by the cortex, whereas individual muscles are innervated by subcortical centers. So this is where we need to look to get at the crux of the problem. The fundamental evolutionary clue to the neurology of infantile esotropia lies in the finding of monocular nasotemporal asymmetry to optokinetic targets. All children with infantile esotropia show brisk nasalward optokinetic responses and absent temporalward optokinetic responses when fixating with either eye. So if you cover one eye and spin the optokinetic drum nasally in front of the open eye, they'll go clickety, clickety, click. But if you spin it temporally, they'll just fizzle out and be unable to follow the drum. And this is true for both eyes. Monocular nasotemporal asymmetry provides the neurologic substrate for latent nystagmus, wherein either fixating eye causes a conjugate fixation with either eye causes a conjugate nystagmus with a nasalward slow phase and a temporalward refixation saccade for each fixating eye. So this nasalward optokinetic bias drags the fixating eye toward the nose, and then they have to make a temporalward refixation saccade. Now, what's so amazing is that even years after successful strabismus surgery, patients with infantile esotropia will always retain their monocular nasotemporal asymmetry. So if you examine a 60-year-old who had surgery at age 3, they'll still have the monocular nasotemporal asymmetry. So it serves as a kind of footprint in the snow for infantile esotropia. Now, what's so interesting is that monocular nasotemporal asymmetry exists in lateral-eyed afoveate animals, and it's used for the detection of full-field optokinetic flow. Normal human infants show monocular nasotemporal asymmetry within the first 6 months of life. So the persistence of monocular nasotemporal asymmetry in infantile esotropia is an atavism, meaning it's a throwback to an earlier evolutionary form that was lost in succeeding generation, but then reactivates and gets a foothold in children with infantile esotropia. Monocular nasotemporal asymmetry is generated by the nucleus of the optic tract and the dorsal terminal nucleus of the accessory optic system. Now, I know when you hear those words, you get the oral equivalent of dyslexia because those words are just gibberish. But these are simply subcortical midbrain nuclei that subserve full field motion detection. And they're normally turned off early in human infancy, so they just don't play a role in the mature binocular visual motor system. And that's why you don't learn about them. And these subcortical nuclei generate visual vestibular eye movements in lateral-eyed animals, meaning that they send their visual motion signals down to the vestibular nuclei, which then rotate the eyes to respond to optokinetic motion and thereby minimize retinal slip. This subcortical circuitry for optokinetic asymmetry is shared by all vertebrates. Now, when you read the comparative biology literature, you're struck by the fact that all of the unique eye movements that we see in infantile esotropia, latent nystagmus, primary oblique muscle overaction, dissociated vertical divergence, each of them correspond to distinct subcortical visual reflexes that are operative in lateral-eyed animals and that serve a specific function. And the subcortical anatomic pathways for these movements have been well established. In fact, one of the defining features of infantile esotropia is the persistence of these subcortical visual reflexes that you don't see in other neurologic conditions. So these subcortical visual pathways are integral to the pathogenesis of infantile esotropia. And this is why the neurology of infantile esotropia is conspicuously absent from neuro-ophthalmology textbooks. To understand it, we have to shine our flashlight into the basement of the brain, where the old ancestral subcortical reflexes that normally get put to sleep in infancy remain activated. So let's take a few minutes to walk through the neurologic pathways that give rise to infantile esotropia. See if I can use this pointer. When you look at this diagram as if looking from the sky, this is the left eye, this is the right eye, and the left eye is receiving nasal-ward optokinetic input in the form of horizontal movement to the right. It's the nasal retina in lateral-eyed animals and in humans with infantile esotropia that's selectively sensitive to nasal motion. Now, the trouble with our understanding of infantile esotropia is that we've put our magnifying glass on this part of the brain, which is the visual cortex, and assume that there must be a primary defect in binocular vision, when actually it's much more likely that the primary problem is in, let's see if this didn't go, is in this part, in the subcortical visual pathways. So let's now try to examine these subterranean visual pathways, these visual pathways that are in the catacombs of the brain that have so far eluded us in the field of neuro-ophthalmology. Because the entire fish retina is nasal retina, it's a lateral-eyed animal, so each eye only sees temporally off to the ipsilateral side. The motion signal crosses entirely within the chiasm, like our nasal retina does, and goes to the contralateral nucleus of the optic tract and dorsal terminal nucleus of the accessory optic system, which are selectively sensitive to rightward motion, which is nasalward for this left eye. Now, I'm going to show you a few nuclei, but just try to get the general concept. These subcortical nuclei process horizontal optokinetic motion, then send their signal down to the dorsal cap of the inferior olive, and then down to the cerebellar flocculus, which processes visual vestibular movement, meaning visual motion input. Now, the cerebellar flocculus then sends its output signal up to the vestibular, or down to the vestibular nucleus, which integrates visual motion, visual optokinetic input from the eyes with vestibular head motion from the labyrinths. So visual motion and vestibular movement get integrated within the vestibular nucleus and sends its final output signal to the oculomotor nuclei, which then program the extraocular muscles to minimize retinal slip. So this is our subcortical visual vestibular roadmap, and as we will see, this ancestral circuitry in the basement of the brain controls visual motion detection in lateral-eyed animals and also generates infantile esotropia. Everybody take a big breath. Systole, diastole. Now, because monocular nasotemporal asymmetry and cortical motion asymmetries have been detected electrophysiologically within the visual cortex of patients with infantile esotropia, some have inferred that essential infantile esotropia must be caused by a primary problem within the visual cortex. But these findings are exactly what you would see if the cortical foveal pursuit pathways secondarily reconfigured themselves to match the pre-existing subcortical template for full field OKNs. In other words, under monocular conditions, the visual cortex gets rewired to match the subcortical template. And this is called the Hoffman hypothesis, and this has been shown to be occurring in infants who don't have binocular vision. So although you can find monocular temporal asymmetry within the motion pathways of the visual cortex, this is the effect rather than the cause of the problem. The primary cause lies within the subcortical visual motion circuitry. And I think that's been the conceptual oversight in the cortical model for infantile esotropia. Infantile esotropia does not require a primary cortical defect in binocular vision. Indeed, there's no evidence that one exists. So how does this all fit together? Well, we all learned in medical school that ontogeny recapitulates phylogeny. In humans, the subcortical optokinetic system is operational within the first few months of life until cortical binocular vision develops. And that's why a newborn baby won't follow a pen light, but will show optokinetic responses to a full field surround even on day 1 of life. As our cortical motion pathways, binocular cortical motion pathways mature, our subcortical motion system loses its plasticity and gets shut down forever, and this occurs at about 2 to 3 months of life. Now we know that infantile esotropia gradually develops during this critical period when the subcortical motion pathways normally are extinguished. So here's the question: could retained subcortical neuroplasticity, in other words, if they don't get shut down like they should, lead to persistence of simultaneous subcortical optokinetic input from both nasal retinas and gradually drive the eyes into the front, drive both frontally placed eyes into an esotropic position? Well, the answer in lower animals is definitely yes. Colowine showed this in rabbits, and more recently it's been shown in zebrafish. And I want to just play you a video to show you how strong this optokinetic reflex is in zebrafish. In other words, if there's a tonic optokinetic drive, would nasalward binocular input tonically drive the eyes in? So I'm going to show you disjunctive optokinetic input, temporal input to both eyes, nasal retinal input to both eyes, and let's see what happens to eye position. There's at least a 50% chance that this will play. Okay. Temporal, you see both eyes go exo. Nasal, both eyes go ESO. Little flick of the tail there. Temporal, both eyes go exo. So we'll look once more. Temporal, exo. Nasalward, ESO. It's like the evangelists say, you have to want to believe. So binocular nasalward optokinetic input definitely has the potential to drive each of our eyes into an esotropic position. Now, at the cortical level, think about it. The nasal retina of the esodeviated eye is always suppressed, as shown by this gray area. This eye is looking straight at the target. This eye is turned in relative to the target, and the nasal retina is suppressed, and that's why children with infantile esotropia don't have double vision. So the two eyes cannot generate simultaneous nasalward optokinetic responses at the cortical level, but at the subcortical level there's no suppression, so both eyes can be pulled in simultaneously, just like in fish and in rabbits. In other words, you can have cortical suppression of one eye and still have the two subcortical nuclei that are hyperfunctioning because they're stimulated at a completely different level. And the beauty of this mechanism is that the subcortical optokinetic system can remain operational despite cortical suppression of the esodiviated eye. So in conclusion, infantile esotropia conforms to a state of extended neuroplasticity in which the subcortical visual pathways fail to shut down in the third month of life as they normally do, allowing an early subcortical nasalward optokinetic bias to simultaneously drive each eye into an esotropic position. Accordingly, infantile esotropia is not a broken system. It doesn't require a neurologic lesion. It's not a soft sign of neurologic disease. It's an older ancestral system that retains its function so that you get innervational overaction of specific extraocular muscles. And the supreme irony of this mechanism, of this subcortical mechanism, is that as your visual cortex becomes monocular, you're either fixating with the right eye or the left eye, the subcortical visual system becomes binocular, meaning that both nasal retinas are activated simultaneously at the subcortical level to drive the eyes inward. So I've come to view infantile esotropia as an evolutionary footprint. In humans, it's like the two nasal retinas are repositioned into the frontal plane, but they continue to do the same things that they used to do in lateral-eyed animals. And if you think about it, this solves the problem by restoring horizontal direction binocularity in children with infantile esotropia. Whichever direction an object is moving, the child can now follow it with the eye that's receiving nasalward input. And we've recently reported a spontaneous fixation shift in children with infantile esotropia induced solely by a directional reversal of the horizontal optokinetic motion in children with infantile esotropia. I'll end with a quote from William Harvey, who almost 500 years ago used comparative biology to study and define the human circulatory system. He presciently noted, "Nature herself must be our advisor. The path she chalks must be our walk. For as long as we confer with our own eyes and make ascent from lesser things to higher, we shall at last be received into her closet of secrets." Thank you.